Hello, and welcome to this week's episode of Giant's Healthy Innovators Live TV. Once a week, we bring to you some of the world-leading healthcare innovators who are taking the best technology innovations and driving them into support and to enable healthcare to address some of the largest challenges and needs of society. To begin with, I'd like to thank our sponsors, Vodafone Business, Barclays Bank International, and our McKinsey & Company. Thank you very much to all of our sponsors. We love working with you guys and really glad to have your support. My name is Barry Schreier, and I'm the founder of Giant Health. These weekly TV shows are brought to you by Giant Health, which is a global community of nearly 200,000 people around the world. Everybody whose business is healthcare, technology, and innovation is the community that we're ambitious to support. So we'd love to hear from you. Please visit our website, www.giant.health, where you can learn more about Giant Health, our community, our weekly email newsletters, and our annual event, the Giant Health Event, which is taking place in November this year. According to the Financial Times, it's Europe's largest, most valuable annual healthcare innovation event. So we'd love to hear from everybody who's watching this episode and hear from you regarding what you'd like us to see at that event and how we can support you and your business. So today I'm very, very proud to introduce you to Tomasz Gordnik. Hello, Tomasz. How are you?
Hi, Gary.
Thank you for joining us and really glad to have you on board. Tomasz, just to begin with, if you can tell us what your role is and what your business is, and then we can talk about some of the big challenges in society and some of the big opportunities with technology innovation in healthcare.
Thank you. Yes, I'm the CEO and founder of a company that's been in the digital healthcare space for the last 30 years. And I'm also the co-chair of the Open EHR Foundation, whose mission is to provide standards for managing clinical data.
Excellent. No, that's great. Thank you very much. So a vast majority of our listeners obviously have a career in the healthcare sector, and in particular, they're directly involved in technology and innovation. But just in case some of the listeners out there aren't directly involved in the healthcare sector, what is EHR, and can you elaborate a little bit about that?
Yeah, EHR stands for Electronic Health Record, and it's understood differently in different parts of the world. So in the US, EHR actually means the application to manage health data, and mostly in Europe, we think about the EHR as the health record, so the data part.
Okay, excellent. Is this the same as other acronyms that we hear? EPR, Electronic Patient Record, and EMR, Electronic Medical Record. Are these all the same?
Yeah, but those would be applications. So the record itself, it's used interchangeably. What we do is we believe the EHR is your health record, regardless of which application is used to create or consume the data.
Yes. Okay. No, that's a helpful clarification. Thank you. So what are some of the issues in healthcare and in national healthcare systems? For example, do you have large EHR providers? Do they try to monopolize with their own unique standards and this type of thing?
Yes, well, I don't think we have enough time to go into all the issues because there are many. I mean, healthcare is, of course, a huge field, and it's relatively complex. You know, I come from telecoms, and most of the people that came with me thought that healthcare was going to be much easier than telecoms, but you find that it's much more difficult, and a lot of the difficulty has to do with data. The fact is that data in healthcare is different than in other industries in a way that we quickly realize we would like to keep the data for the lifetime of the patient.
Sure.
And that's 100 years. So, there's no technology that lasts that long, let alone applications.
Yeah.
So this difference in life cycle between data and applications creates all kinds of issues.
Yep.
So you will recognize it's not the same in other industries. So the longevity is one issue. The other issue is, of course, the complexity. Trying to accurately describe a patient condition is incredibly difficult. And you want to be as accurate as possible because this data will be depended on by pharma, by your physicians, by the whole care community providing care for you.
Yes.
So it's really complex. And then on top of that, we have the vendor community, right? So you are right. The vendors, in most cases, see locking customers into their data models as a way to control revenues for the future. So it's really a business issue when you're talking about vendors. People think it's technical, but it's really not.
No.
It's a business model issue. That's why it's difficult to break.
These ambitions of the vendor, naturally, we understand their commercial goals there, and that's what they're trying to achieve. How does that impact either positively or negatively on opportunities within healthcare and costs to healthcare systems?
Yeah, well, I must say it's the impact is pretty much negative, because I think there's now it's quite clearly a battle for data. Just like in other industries,
right?
It's the same battle in healthcare, except that this type of data is much more important for the users and, of course, for the patients.
Sure.
To be left to vendors to manage and control. So I think what we're now seeing, and I must attribute this in large part to COVID, is that governments, regions, healthcare providers, and even patients are recognizing that really, healthcare IT means that the data is more important than the applications.
Okay.
Because I mentioned the longevity, but also the importance of data as applications change is huge. Things that happen to you during birth have an impact on your health throughout your life. So I would say that this issue now with COVID, we saw that a lot of governments couldn't make good decisions because they didn't have the right data.
Yeah.
So if for the last 10 years, I've been convincing, customers and actually governments that data is more important than applications, now it's front and center. People get it. There's no need to explain that anymore.
No, that's interesting. What's the famous phrase? With crisis comes opportunity. And
absolutely.
Naturally, the pandemic has been a horrible crisis and a tragedy for many people around the world. But maybe there's a silver lining, so to speak, regarding what might happen in terms of healthcare systems and their approaches to data.
Exactly. I've even joked that it's healthcare is so hard to change. It does take a pandemic. Healthcare IT is really hard to change.
Yes. Yeah. So we have this issue, which is data for life. Data is for life. The lifetime of a person could be 60, 80, 100 plus years. Technology never lasts that long. Therefore, there's a strong logic to separate data from applications, if I understand correctly what you're saying. So
absolutely.
Is that what Open EHR is all about? I've heard this phrase. Could you help us to understand what this is?
It is. So OpenEHR is actually a community which builds specifications for digital health infrastructure, and it specifically focuses and starts with the data. Okay. So the premise is that if you think about today, people buy applications without thinking about the data.
Oh.
So this really needs to change, because in the end, as we've just talked about, the data is more important and it needs to outlive the application.
Yes. Yeah.
So an example which I always give is the imaging world, right? The PACS systems. The PACS systems have standardized the data format 25 years ago.
Okay.
And today you can actually switch out a GE with something else or the other way around without touching the data.
Wow.
So this is the kind of functionality OpenEHR and what we are doing is trying to bring to healthcare, where actually your data record would be independent of applications. Right. And this is absolutely critical. We like to say that nobody has a monopoly in innovation. So you cannot say that you have a vendor and all you need for the future will come from that vendor. It will not.
Sure.
So you need to be open and use your data to connect other applications. And this, of course, is obviously what the users want, what the patients want. And it's really the business model of some vendors, mostly the big ones, that are keeping this from happening.
I understand. Yes. Once again, I understand the logic of the largest vendors from the perspective of their own, personal commercial ambitions and their obligations to their shareholders. However, there could be a conflict between those goals and the goals of society or a healthcare system. Is OpenEHR like the open source movement more broadly? Is it fair to compare it, for those of us who don't have a career in technology, is it fair to compare it with things like the Linux versus the Microsoft versus the Apple operating systems?
In a way, because the content that OpenEHR creates is open source. It can be used by anyone without payment.
Right.
But the products built on top could be open source or commercial. Our company, for instance, provides a commercial platform which runs OpenEHR, which means that the content, the data models, and stuff like that is free. But of course, you buy the platform to run those data models. But you have open source alternatives as well. So it is in a way connected, but not entirely.
No. Is this a little bit like many years ago, the kind of Linux Red Hat type of ecosystem?
Could be, but I don't think, it's fair to say that we absolutely need to have. I call it more vendor neutral than open source. I think is the more correct explanation. Okay. Because you don't want it tied to any single vendor. You want the community to actually define the data models they will use. Okay. And then it depends on whether the software is commercial or open source. It's not really the main point. Okay.
No, that's a helpful clarification. Thank you. I guess I'm just looking over time, over the past 20 or 30 years. It was the Microsofts and the Apples with their closed, what do you want to call it, proprietary platforms, which in fact, for right or wrong, seems to dominate in many markets and industries. And could one argue that it was better that there were these large, successful vendors that locked you in order to have the resource to build the best products? And if it was an open source free for all, what do the customers get?
Yeah, but you have to make a big separation here, because those products were mostly B2C. So they were consumer-based products where consumers didn't want to pay or do not like paying for something that they can get for free from a big vendor. Healthcare is completely different. And I will also argue that, it's one thing sharing your data about your friends' network and things like this. It's a totally different thing sharing your health data with other people, because what people don't realize is that banking data or stuff that gets stolen, you can open a new bank account. If you have an allergy or some genetic mutation, that's yours forever. You cannot change that. So if somebody steals that, there's nothing you can do to make it irrelevant. It stays there. So healthcare data is different. And that's why I think we need to think differently about how we manage it. And some countries are starting to think it's actually a national security issue.
That's very interesting. No, that's a very interesting point.
Barry, let me share my screen just for a second.
Of course.
You see it?
Yes, of course. Yep.
So this is a statement by Matt Hancock from the NHS, or the Secretary of State in the UK.
Yep.
And it's interesting that after, I mentioned we've been saying this for years, but now with COVID, the data is front and center. And the realization is that, as you can read here, people are starting to wake up to the fact that it isn't the vendor's data. It is the patient's data and the health system's data, but it's never the vendor's data. So what they're actively saying here is if it's not accessible, and it's not in many cases,
yes,
it's really a barrier to research and innovation. And then he goes on to say that the way to solve this is to separate data from the application. And he's actively talking about a consistent data platform across the NHS. Now, it's important to say that it doesn't mean one big database.
Okay.
It just means that the data in all cases is in a consistent format, so you can put it together when needed. And this is exactly the approach we've been championing for 10 years with our platform. It's just that, again, COVID has really made people realize that this makes all the sense in the world. And if I mentioned PACS and imaging, have been doing this for 25 years. The structured data, the data that is really important for analytics, AI, decision-making, is the one that is still locked in the silos of the applications.
Yes.
And just maybe to mention another quote. We talked about data for life, and I think it's a really good expression because health data is for life. And of course, it's not just for one system, one application, which is the way it's done today, to be honest. And EY in this research paper really described the architecture which gets us into this new environment, which is very different. You see on the left how data is coupled to applications.
Yes.
You see on the right how actually you would like to put this data at the center in a vendor-neutral format, and then have all the applications, the devices, AI algorithms, everything that generates or consumes healthcare data, it would connect to this centralized layer.
Okay, that's very interesting. This slide is extremely insightful. Can we look at the slide a little bit more, or do you have another slide you want to move to?
No, I think that's more than enough.
Let's look at the slide though, Tomasz, because I want to ask about the AI donut on the right-hand side.
Yes.
And could you help our listeners to understand further, looking at the situation on the left-hand side of the slide, the situation that we have now, are there barriers to the deployment of machine learning and AI activity? Where are the barriers as it stands right now for making best use of machine learning to interpret and come up with new learnings and ideas and possibilities with that in the current setup?
So most people who are involved in AI will tell you they're struggling to get quality data on which to base their algorithms. And this is true across the world. So probably China is doing really well not because they have better data, but because they don't have many legal implications or limitations on using the data from the patient.
So
Europe, as you know, has GDPR, which severely limits how you can use data.
That's right.
And of course, in most cases around the world, you have this situation that you see here on the left, where data is spread out among applications. So a major task is bringing this data together, unifying it, normalizing it, as we call it, and making it useful to build algorithms.
Yes.
And I think this is a really expensive and difficult proposition. And having a unified data layer, of course, would solve this problem and enable AI to move much faster and build these algorithms.
I understand.
Better.
That's very helpful. So it's the fragmentation of the ecosystem that we have right now, which is a barrier for the machine learning and AI people that are looking for larger and more, if you will, higher quality data sets to work with?
Yes, absolutely.
And the bigger the data sets for them, the more value they can get out of it, and the more AI can do things.
Also, and Barry, think about this. So today we're mostly buying applications for organizations, right?
Yeah.
What we need to be thinking about is building the record around the patient. Now, obviously, the patient goes into several institutions, right? And we are just recently starting to see applications which are produced around a consistent patient record and then sent out into the organizations that provide the care. So an analogy would be, if you think about how we used to deal with documents, we used to be sending attachments in emails.
Right.
And the problem with that is you lose control of that data, right? So it could be forwarded to somebody else. You cannot recall it. You don't have any audit trail who has seen it.
Yes.
It's the same today when we're sending data around. Now, contrast that with how we're getting used to, Dropbox and Google Docs and all of these things where we send around links, but we work off the same data. So this is the new world. So this is the architecture on the previous slide, which talks about the fact that the data should be built around the patient.
Yes.
And then we access this data. And the good thing is here we have full control over who sees what. It can be patient consent if necessary. We can revoke this privilege, but we can also have a full audit trail of what happened with the data. The most advanced systems are involving their patients much more in their care, which means they're giving them full access, in some cases, even co-producing the care record. You have your devices, you have, a patient will immediately spot a mistake that was made from a transcript of his conversation with the physician. And I know they've been doing this in Boston years ago.
Yes.
I forget what they called it, but it was Halamka that was doing this. And it improved the quality of data immensely. But just giving the patient data will improve patient engagement, and we all know that improves outcomes.
Yes, exactly. Oh, Tomasz, that's extremely interesting because, of course, we have a much larger challenge across all societies, which is the exploding costs of the delivery of healthcare, which are unsustainable, and the growing demand on healthcare services with new things like aging populations and type 2 diabetes and obesity, therefore, once again, unsustainable. And the fact that healthcare around the world actually is a sick care service. You phone the doctor when you're unwell, and therefore the challenge for societies is to figure out what you just said, how to engage the patients more and to get them more involved in the awareness and management of their own health, because there's a necessary requirement across all societies to get people to concern themselves with wellness and to move away from sick care towards well-being, which has to be patient-led, doesn't it?
Yes.
So what you're talking about right now is extremely relevant in the biggest picture for healthcare and society. What can we do? How can we do it? How do we encourage patients to take their own health more seriously, to concern themselves with their own health more? And if we can get them to buy into this issue of awareness of their own patient records, and like you just said with the Boston case study, even correcting any inaccuracies in their own patient records, that's a very big, powerful step forward, isn't it?
It is, and it gives them some empowerment and actually some responsibility, because you know that the biggest issues with patient care is when the patient doesn't take responsibility for their health and doesn't follow the prescriptions or stops taking medication. These are the things. Behavior change basically is something we're trying to achieve, and the engagement here is key.
I'm just writing this down. This is so interesting and relevant for quite literally all the conversations we're having around healthcare. So thank you for sharing that with us, Tomasz. Extremely interesting. What are looking at digital health platforms, what are some of like the UX issues, and does that make a difference?
Absolutely. There's a lot of research being done that there's a strong correlation between the IT systems and physician burnout.
Oh.
So Stanford published a study where 60% of physicians, 59 I think, actually requested a complete overhaul of EHR records, as they called it.
Wow.
So this has to do with usability, and of course it's different country by country. US is especially a big issue because of what we call defensive medicine, which means that they have to document everything so that they're not sued for not doing enough.
Yep.
This creates a huge burden on clinicians, keep them away from patients. They see themselves as clerks, and it's actually a huge issue. So technology will help here. We now have speech recognition, a number of different ways of getting this data, but it's still a long way off. So usability, I think, for the end users, in this case, physicians and nurses, is paramount to move forward. But the digital health platform is basically, as defined by Gartner Group, it's three things. First is this much better, improved, personalized UX.
Right.
We're used to this from other applications, from the apps on the phone. Users actually want the data they need, not all the data, and not the data that, not missing data that is critical.
Yes.
Personalized. It has to be personalized. The other thing is IT departments across the world in health are really struggling to provide the necessary applications, meaning they have a huge backlog of things they need done.
Okay.
And we need a different way of building applications. And you've heard about low-code tools or even no-code tools in some cases, where analysts can put together compelling apps which the physicians and nurses can then use. So it's the user experience, it's the low-code tools to enable quickly accelerated software delivery.
Yep.
And then, of course, again, it's the data layer. The third piece is a vendor-neutral clinical data repository or electronic health record, however you want to call it.
Yes.
So these are three key pieces of what we call a digital health platform.
Okay. In these digital health platforms, could you help our listeners to understand further a little bit more about this low code or no code concept? What is that to the layman, and why is there value there?
Yeah, so the idea is, of course, that you would not need just, or you wouldn't use just programmers to build applications.
Okay.
So if you think about how the software development process goes, you have analysts that go out to users and ask for input on what needs to be built.
Yes.
So these guys have the information of what needs to be built, but they need to pass it on to programmers to actually build the code.
Oh, okay.
And then they come back and they need to test the code and so on in order to hand it over to the end users. So shortening this circle where the analyst can actually use powerful tools, which we call low code or even no code, to build the application instead of the developers. Now, we have to be honest, you cannot build every application like this. The most complex ones will need programming. But a lot of stuff can be done using this approach. Mm-hmm. And of course, it's much, much quicker because you can actually co-design and co-build the application with the end user, in this case, the physicians.
So therefore, there's, if you will, less people in the production equation, and a more direct link between end users and product development. Less likelihood of things getting lost in translation, so to speak. Just talking about the idea of low code and no code, and am I right that this maybe shortens the distance from development of product with end users in mind, and getting what they want, and things not getting lost in translation, so to speak, because you have fewer people involved in product specification, development, and production. Is that correct?
Yes, but the main focus is speed. Okay, so as I mentioned before, there's a lot of backlog in healthcare. People are, when COVID hit, everybody had to deal with that, so they couldn't do their regular job of building applications for end users.
Yeah.
So this is really a big problem because things are changing so quickly, and without having good applications that end users can use, it's just impossible to do care today.
Sure.
So shortening the cycle and actually broadening the base of people who can build applications. You have to realize that, the healthcare is not the most attractive in terms of salary for IT people. So IT people get sucked away into finance, into other areas.
Yes.
It's really hard for health systems to hire programmers, to be honest.
I understand.
So we need a better way of building applications. And this low code is not specific to healthcare. Actually, I would argue that in healthcare, it's a little bit more difficult than in other cases, because in other cases, you use it's called form builders to actually build forms,
right?
But then it somehow stores data. Well, this doesn't work in healthcare because we talked about data before, how it needs to be properly managed, how it needs to outlive applications, which means it needs to be done first and then the forms built on top. And actually, that's how we do it. We have a low-code platform, but the big difference with others who come from other industries and, like we did initially, think that healthcare is going to be easy. It's not. So we built a solid data foundation because we have the data platform as well. Mm-hmm. And then we use that to build the low-code. We use low-code tools to build applications from that base.
Yes.
And I think that's really the key message here. If you try to do healthcare top-down from the user interface to the data, you will fail because it's the data that it needs to stay for longer than the application. So you really need to focus on properly structuring the data. And this is actually what OpenEHR does.
Yes, yes. Oh, that's very, very interesting and quite relevant for our audience. So thanks once again, Tomasz, for sharing that. We'd love to hear a little bit more about your business better and what you guys are doing. So if you could help us to understand that, please.
Yeah, so we have been in healthcare IT for 30 years. We have actually renamed to Better about 3 years ago. Before we were called Marant, so some people know us by that name. Okay. But really, it's been to focus exclusively on healthcare, and we are now actually in 15 countries. We have now a company in the UK. We're originally from Slovenia.
Okay.
We're just opening an office in 3 German cities in July 1st.
Oh, superb.
And probably Barcelona as well by the end of the year.
Wow.
So we're growing really quickly. We have about 120 employees now, but we have over 120 customers using our platform.
Nice.
Now, some of them are very large. We run the clinical data for the entire city of Moscow for 12 million patients, which is the largest, I would say, single EHR in the world. And this is not like a shared care record where you send off data from your clinical systems. This is the clinical system.
You're kidding. For all the citizens in Moscow.
Yes, it's actually 1,000 institutions, hospitals, primary care centers. And it proved really valuable when they were when they needed to do vaccinations or of course testing, because they have a single record for every citizen of the city.
Yes.
Now, the interesting thing is that Catalonia in Spain is now going after the same approach. So they have decided to use OpenEHR to underpin their entire healthcare system. It's about 8 million people.
Amazing. All on your platform.
No, this is still not decided, but it is on OpenEHR. So this is going to be a tender coming out in the fall.
Let me telephone the mayor of Barcelona and tell them that they need to go with you.
Well, we're working on that, absolutely.
Okay.
But then we have other examples. We have 8 of the biggest hospitals in Germany, so Heidelberg, Charité Berlin, and so on. They're using a different approach, and maybe I can share the slide again.
Yes, of course.
To show you what I mean, because it's much easier.
Sure, this is interesting and very relevant for our.
Can you see the slide?
Yes.
Okay, so we talked before about healthcare data inside an organization like a hospital, but if you extrapolate this to a region or a city like Moscow, what you will find is that you can do the same thing. It doesn't mean centralizing the data. You can still have the data at each site, but it has to be in the same format. So you need governance to build what we call one patient, one record. And you can see here, it's built around the patient, even though it's distributed in different organizations. But with governance of the data models, you have then a choice of apps and vendors which can run across this ecosystem. And it's apps that are built once and shared among the group. Now, this is the model used in Germany by the 8 university hospitals, who actually normalize data from their existing systems and then share it for research. Now, Moscow is using a different model, which is this, which is centralizing the data because they can legally do it. It's really hard in a lot of countries to do this. But these two are equivalent. So exactly the same record. One is distributed, the other is centralized.
Right.
Now, in terms of the company, we're really proud that Gartner put us on this slide. As a relatively small company, of course, we're in great company here. And this is the capability of the digital health platforms that was just announced end of last year.
Superb.
So to summarize, we are absolutely after, just a second, are we back? Yeah.
Yes.
So our mission is to empower care teams to help provide better care. And we do this using 3 things. One is improving the user experience. We talked about how important that is. The second thing is reducing that backlog by accelerating digitalization using local tools. And the third thing is, of course, basing everything on consistent and quality health data models to enable this shared or a single patient record built around the patient, not around institutions.
Exactly, yes. Where the entire platform starts with the patient and the patient's data rather than what vendors are offering and what is the fashionable software and hardware of the moment.
Exactly. And I think, I mentioned we're now in 15 countries growing really quickly. We're absolutely looking for people around the world who can help in our mission.
Right.
We're not in the US yet, but we are looking for partners. We just signed partnerships with EY, with Atos, with CGI, Microsoft, a number of the big players, because we are not a services company, which is also important. We're a product company.
Okay.
So our platform is used in some cases as OEM. So the largest vendors in the Nordics, Tieto, for instance, use our platform inside their EHR. But of course, we are also supporting some of these large customers, but usually through partners.
Understood. Well, Tomasz, it's a very impressive story. And obviously, congratulations on what your business has accomplished over the years. So you mentioned that you have ambitions to expand internationally.
Yes.
We hope that we have many listeners around the world. Are you looking to talk to who, for example? Is it the IT procurement decision makers of hospital groups, or what are the types of audience? Who is it that might be listening to these episodes? And we would like to invite them to talk to you.
Yes, it is absolutely the large health systems who are struggling with putting data together. You know, where you have mergers and acquisitions, there's a big chance that they don't use the same software.
Okay.
So there's a huge need to put the data together around the patient.
Right.
You also have to realize that even the largest systems, like, for instance, Kaiser in California, they're a big user of one of the big systems, but 50% of their IT is not that vendor. So there's a lot of applications. You know, we have customers that claim they have 6,000 applications. You know, where does that data go? So it's not, even if you have the mega suite, as we call it, there's a lot of room for improvement in the other areas. And
Absolutely.
Of course, managing patient data independently of the application, I think, is well accepted now.
Yes, absolutely. I mean, to me, the case is absolutely clear, and so you've presented it in quite a helpful and compelling format. Thank you for that. What else, other than your ambitions in terms of international expansion, your interest in speaking to IT procurement decision makers in big hospital groups? Anything else coming up with your business? Any recruitment vacancies you have that maybe people in our community would like to know about?
Yeah, we're actively recruiting. So we've added 20 people since the beginning of the year. We're adding another 20 by year end. I mentioned Germany opening up as a company, subsidiary. London as well. We've been there for a year and a half. Barcelona. So to be honest, I think we're actually getting ready to go across the pond to the US.
Okay.
We want to actually make sure that we have a good footprint in Europe first, because for some things like prevention and things like that, Europe is way ahead of the US. Community care, social care, especially the Scandinavian countries. And the nice thing is these are the countries that are adopting this model, OpenEHR. You have to realize that 4 of the biggest vendors in the Nordics use OpenEHR.
Wow.
And that's really an indication of how far this has come.
Absolutely. Excellent. Hey, well, look, this has been a fabulous conversation, Tomasz. It's great to be in touch with you, and we really appreciate your time. It's great to hear about your business, and it's just so fundamentally important, isn't it, for healthcare systems around the world to recognize the challenges, the requirement to put patients in the middle, the requirement to try and figure out how to separate data and patient data, which lasts for up to 100 years or more, from products and services that are for sale today and might not be around tomorrow.
Yeah, and just a final thought, think about data first and application second. That's my advice to healthcare IT leaders.
Yeah. Not necessarily a natural element of what's happened in the past few decades.
Exactly.
But I would certainly think from your very intelligent and interesting and insightful comments today, not the way things have been, but the way they should be and the way they could be, and certainly the way we hope they will be in the future.
And it's happening. We can see this. And again, unfortunately, we have to thank COVID for that.
Well, exactly. The silver lining.
Absolutely.
Tomasz, it's been a great pleasure to speak with you. Thank you for your time, and congratulations on everything you and your team at Better have accomplished. We're absolutely big fans of yours, and so you can count on us to champion what you guys are doing.
Great speaking to you, Barry. Thank you.
Thank you very much.
Once
again, this has been Giant Health's weekly episode of Healthy Innovators Live TV. We'd like to thank Tomasz Gornak and everybody from Better, and very pleased to hear about what you guys are doing, and very proud to be championing and supporting your important initiatives and the great business and services that you guys are providing. We'd also like to thank our knowledge partner, McKinsey & Company, and our sponsors, Vodafone Business and Barclays Bank International. Thank you. We love working with our sponsors and really glad to have you guys on board as valuable collaborators. One more important point, these episodes are brought to you by Giant Health. Please go to our website, www.giant.health, to learn more about our business. We're a global community of nearly 200,000 people. Everybody whose business is healthcare, technology, and innovation. We invite you to write to us or message us. We'd love to hear what you're doing in healthcare and technology and innovation. And we hope to see you at the annual Giant Health event, which this year is 30th of November, 1st of December. And so we're looking forward to engaging with everybody then. Thank you very much and hope you've enjoyed this episode.